Morning, everybody. It's very early here, especially for those of us on the that are from California or the West Coast in general. So thank you guys for joining us. And for those of you that are at home watching online, welcome. We're excited about this conversation. I'm Tracy Dixon Salazar, Executive Director of the LGS Foundation. And before we get to the program and the discussion, which I hope is going to be a great discussion, I want to talk a little bit about how we got here and what we're working on at the LGS Foundation. So this is our Meeting of the Minds seminar series, and it's part of our Meeting of the Minds conference program. We had a conference in September of this year where we focused on disease-modifying therapies for LGS. And I'm going to talk a little bit about what's come out of that as actual outcomes from the foundation, which we're really excited about. So first of all, the way that we have been, let's see, one slide of answer. Nope. All right. Tech issues, of course. Give me just a second. All right. If there's a tech problem, I'm going to have it. I have other talents, but it's not tech. So I just want to talk a little bit about the way that we've been thinking about LGS at the foundation. And many of you have seen this slide. So LGS is all the way over there on the right side of the screen. And this is where you have multiple seizure types, at least more than one type of seizures, slow spike and wave on the EEG, generalized paroxysmal fast activity on the EEG, and intellectual disability, which isn't always present at diagnosis, but appears in most within 5 years of the onset of seizures. And then it doesn't really matter how you got to LGS. The outcome seems to be the same in many cases, and it's very difficult to get seizure control. The children and adults, like my daughter who has LGS, who's 28 years old, are very intellectually disabled and very reliant on others for every aspect of their daily care. And there's premature mortality, and it's a really severe disease with lots of crises. But before that, we've started referring to LGS, prior to that, pre-LGS, because we don't really know what to call it. But you can hear doctors like Dr. Knupp say, they look like they're going LGS on the EEG, right? And there's a number of risk factors. And so treatment-resistant epilepsy usually precedes, in almost all cases, precedes the LGS. There can be another syndrome like West or early infantile epileptic encephalopathy. Before that, they have epilepsy. Before that, they have their first seizure. And before that, they have their etiology. And across this span, other seizure types can emerge. Developmental delay can emerge at any point across this journey. And your etiologies are really varied in LGS. So the best data we have suggests that about half of the cases are from early onset epilepsy, from an injury at birth, stroke, cortical malformations, things like that. Hypoxic ischemia is a big cause of seizures that then evolve into LGS. And then the other half are genetic, and there's more than 150 genes that are associated with LGS that predispose, if you will. So there's this whole syndrome of pre-LGS, and we're looking at our research program because we want to focus on a couple of different things. Everybody has LGS secondary to some etiology, and that etiology leads to seizures, and then the seizures lead to an abnormal brain network. That is what LGS is. So what really came out of our Meeting of the Minds is this idea that we want to understand the brain networks of LGS. We want to understand slow spike and wave. We want to understand GPFA that you see on the EEG and LGS, because that epileptic network is represented by anatomical regions in the brain. And those anatomical regions are made up of cells, which are made up of nuclei. They have channels on the surface. They signal and they communicate with each other. And so what are the substrates of the network? But we also don't want to neglect looking at pre-LGS. And there's a lot of great work that's going on there. And so we're really looking to focus our research program on these areas of LGS. What's the network? Can we target the biology, the underlying biology, once the science tells us what that is? And then also, can we look early? Because we know anecdotally that you can prevent LGS in some cases, right? If you can get seizure control. But we also know anecdotally that in some cases you can reverse LGS. So kids who have slow spike and wave get surgery, slow spike and wave goes away miraculously in some tiny number of children. And then, they go on to live, a generally normal, typical existence if you get it early enough. So this is how we're thinking of it, pre-LGS and LGS, and focusing our research program. We've done a lot of work over the last couple of years asking families what's important to them. And LGS is a really severe, horrible disorder. And you may remember Maslow's hierarchy of needs from psych class. There's an LGS hierarchy of needs. And basically it's death at the bottom. Every year we bury way too many kids that are in our more than 7,000 member community of LGS. Above that is crisis. Our kids and adults are in crisis all the time. They're in the hospital, they're in seizures, they're in nonstop seizures, they had aspiration pneumonia, and they're on the brink of death. Above that is, are they just doing the things that they need to avoid crisis? Taking their meds, eating, sleeping, going to the bathroom, drinking, right? And above that is, do they do any of that themselves? And whatever's above that on the pyramid, we as LGS caregivers don't know, because most of our children and adults never achieve that. And so we're dealing with a huge crisis. And this is really important because as we think about patient-centered research, we want to be very specific about what it is that patients want. So we've begun to investigate that. And this came out of our patient-focused drug development meeting, which we had in 2018. And then at the meeting of the minds that we just had in September, where we brought together more than 200 scientists, researchers, clinicians, and families from around the world, we talked about the landscape of LGS research, looking at basic research in animal models, what do we know, looking at clinical trials, and then looking at the evidence-based medicine pyramid. And I know there's some overlap between each of these figures, but we're trying to get an idea of what the landscape looks like. And we've started to fill in, right? Like what clinical trials are going on and what basic research has been done. And this isn't complete, but this is what's come out of the meeting. And then where are we at in the evidence-based medicine pyramid? And each of the red last names that you see on here are grantees that the LGS Foundation has funded. And so today at 11 o'clock, we're having a luncheon where we're going to be going, our grantees are going to be coming and talking about their research, which is really exciting. But we're building in this landscape and trying to figure out where the gaps are so we can fund within those gaps as we think about pre-LGS and LGS. And what I don't really have time to talk about is all the work we're doing with families to find out what really matters to them. And what came out of the meeting of the minds on our family day was really, they want a transformative treatment, right? And so can we focus on something that's disease modifying, that targets the basic underlying mechanisms of slow spike and wave and GPFA, and not simply the symptoms of seizures or psychiatric issues or sleep or the many, many other issues. And then they also want to know, can we learn from other patients and what is the best care? Is there a certain cocktail that would be the best thing for our kids to go on? So they're doing a lot of work in that area. And that's really led to our Meeting of the Minds series. So we'll be having a Meeting of the Minds conference every 2 years. We just had one this year, so we'll have another one, which will be focused on clinical issues in 2 years. And then our seminar series, which is what this is, will be happening every couple of months. So if you have any ideas for seminars, please let us know. And this is our first. We're going to be talking about how we can improve clinical trials today. Our roundtable is today for research. And then we also have a new RFA, and this is what we're really excited. This came directly out of the Meeting of the Minds in September. Basically, we have $25,000, $50,000, and $75,000 grants. You can apply anytime. You submit an LOI. There are no calls. There are no deadlines. You submit the LOI. It gets rapid reviewed by our MSIB and our families. And then you get asked to invite a full application or not. And that gets rapid reviewed. And if it's meritoriously reviewed scientifically and by our programmatic family review, then you get funded right away. So this just is effectively starting right now and came directly out of the Meeting of the Minds. So, and as we go through the seminar series and start to think about where we might be able to target our funding, we'll also be looking at where we can plug in, whether that's on clinical trials or what comes out of these conversations. So that's it. With that, I want to introduce our moderator and get started. Dr. DeLugos is one of my favorite people. He knows a lot about clinical trials. He knows a lot about kids with LGS, and he's a big advocate for trying to help children and adults like my daughter and many, many others. And he agreed to lead this discussion today with this powerhouse of speakers. So honored to have you, and I am going to stop talking. Dr. Lugos.
Well, thank you, Tracy, and thanks to the LGS Foundation for sponsoring this program. And thank you for our dream team of speakers who agreed to participate. So just to briefly frame what I think we're going to talk about today. So LGS has multiple approved treatments, FDA approved treatments with more on the way. And they have all made incremental advances for some patients. Fewer seizures, different, sometimes improved side effect profiles. But none of those treatments have been transformative. There are still way too many patients with LGS who have way too many seizures and way too many side effects, despite the long list and expanding list of approved treatments. On the other hand, some other encephalopathic epilepsies in childhood have had quite a buzz, quite an excitement lately. And what we want to do with part of the program today is figure out what LGS can learn from those other types of childhood epilepsy. For example, tuberous sclerosis complex. Lots of excitement about anti-epileptogenic therapy, prevention of seizures before they start. And then if seizures do start, mechanistic-based treatments to treat those seizures. What can LGS learn from those advances? Infantile spasms, just as mysterious in many ways as LGS, except there are a group of patients with early diagnosis and early aggressive treatment. The spasms go away, the hypsarrhythmia stops, and normal development ensues. What's that all about, and how can LGS learn from those infantile spasms patients that have a transformative response to treatment? And then there's LGS, very heterogeneous, poorly understood pathophysiology. But that said, what can the typical seizure types and the typical EEG patterns tell us about how to improve trials and help patients? So that's the big picture of what we'd like to talk about today. And our first speaker will tackle the LGS aspect of this. I'm very happy to introduce Dr. Suda Kessler, Associate Professor of Neurology and Pediatrics at the Children's Hospital of Philadelphia and University of Pennsylvania School of Medicine, who will tell us what can LGS learn about itself as we try to move forward for better trials and better treatments. Dr. Kessler.
Thank you, Dennis, and thank you, Tracy. All right, my talk was well set up by Dr. Dlugos and Dr. Dixon Salazar, because it's basically going to just delve a bit deeper into the pathway that was so nicely presented. These are my disclosures. All right, I wanted to start by showing you MRI images of 3 patients of mine that I just saw this within the last month, each of these children, each of the children whose MRIs these are. Each of them has Lennox-Gastaut syndrome. And I wanted to use this to illustrate the fact that etiologies are so diverse. This MRI on the left shows bilateral polymicrogyria, a developmental malformation of the brain that occurs during in utero development. The MRI in the middle shows a malformation of brain development that might have been due to an in utero insult that the child was, or the now adult was born with. And the MRI on the far right is normal. And the child who has that MRI has a chromosome 15 anomaly that didn't result in a structural abnormality that we can see, but they all are affected by tonic seizures, atonic seizures, generalized tonic-clonic seizures. At least one of them is also affected by focal seizures. They all have intellectual disability, and their lives are extremely affected by their epilepsy. So it's a bit of a puzzle that we all recognize, everyone in this room understands. So how is it that these very disparate etiologies, whether it's structural, and structural either bilateral or unilateral, structural or acquired, although we know that the acquired insult needs to be early in life for LGS to happen. And then from a genetic standpoint, if the genetic disorder results in a developmental structural anomaly, you can end up with LGS, or there can be molecular dysfunction that doesn't cause any visible abnormality on MRI. So how is it that all that leads to the same end phenotype? We know that there's a key component of this is age dependence. There's something that happens in early childhood that leads to the LGS phenotype, the LGS network, if neurologic functions are disrupted by seizures at a certain point. Sometimes, but not always, LGS evolves from other kinds of epilepsy. Of course, famously infantile spasms or West syndrome, but sometimes also focal seizures with focal lesions. All right, so I want to focus today on thinking about tonic and atonic seizures, just as a model for thinking about how we learn from very specific, one commonality between all of these patients who have a particular seizure type that we very well recognize clinically, that we can recognize very easily electrographically, and how we can think about trying to understand the mechanisms in order to generalize that knowledge to understanding the mechanism underlying LGS overall. All right, and I will start with a video. So I put this in for anybody in the audience who may not have seen a tonic seizure or an tonic seizure, as this one is. That was the atonic component, and this is the tonic component. And you can see how sudden it is, how very recognizable it would be to a parent or anyone else watching this abnormal movement. You can see that it involves both sides of the body. It's very symmetric. And it's very short. The video isn't going on, but this child recovers from that briefly, but highly disruptive because this child were standing, they might fall, they might injure themselves. And in fact, thank you. Just as a warning. And in fact, that's what happens here. This child is just eating breakfast. A very simple everyday activity, as Tracy was talking about, has an event that she has many, many, many times a day and injures her face. All right. Next slide, please. There we go. All right. So how do we start to understand what is the underlying mechanism of this kind of seizure? Tonic and atonic seizures are so tightly linked, I think, that even though they're not quite the same thing, they, for all intents and purposes, and certainly in clinical trials are. So I'm just going to lump them together. Tonic seizures, the basics that we know are that they tend to have a common EEG pattern, generalized fast activity, which is what you see here. Abnormalities in the EEG show up in every electrode across the front, the middle, the back of the brain, all at once. There's a very abrupt onset, there's an evolution, and it's all at once. But that doesn't necessarily happen by magic. We don't really know actually how seizures happen in every electrode in the brain on an EEG, affecting both sides of the body at once, all at once. The other key finding of LGS is slow spike and wave, which is also a generalized EEG finding, meaning a burst of abnormal electrical activity occurs across all the electrodes at once and can happen repeatedly. This child also has focal discharges. It's also not entirely clear what mechanisms mediate this, and I'll talk a little bit more about what we do know in a moment. I think I just wanted to point out that one other interesting paradox or ambiguity about these two findings that I think could also be informative to us about how seizures work are that sometimes we see them without any clinical evidence of a seizure at all, without, you can have GPFA and no tonic stiffening, no fall. You can have slow spike and wave and no change in interaction or apparent cognition, no absence seizure. So what is it that's happening in the brain that distinguishes those two states? All right, and I will try to get to that in just a moment. But I wanted to pause and talk about this idea for a moment. So trials are often targeted at specific seizure types, and most of our epilepsy drugs are approved for focal seizures specifically. And what we don't know, when I first started thinking about how do we think about, are we doing trials for drugs or trials for syndromes or trials for some combination of those? I initially thought, well, there's sort of two models here. You could have a number of etiologies that all have a convergent mechanism, or each etiology can have its own special mechanism that leads to a specific seizure type. But when I really started to think about it, I realized it's a lot more complicated than that. Maybe there are some convergent mechanisms. There may also be some specific mechanisms that go from an etiology through a clinical phenotype that is in common between those etiologies. You can also have perhaps a similar etiology, one of which leads to a specific seizure type. And one child with that etiology might have a specific seizure type that another child also has, like tonic seizures, but in the context of a broader clinical syndrome. And then there may be, completely separate pathways entirely. And especially in syndromes like LGS and in many other refractory epilepsies, it's uncommon to just have one seizure type. And so we also there are probably many arrows leading to other specific seizure types as well. So it's complicated. The point is it's complicated, probably more than we know. Okay, so how do we start to think about even figuring out the mechanism of tonic seizures, for example? Well, as you saw, EEG is a little bit of a crude tool. We put electrodes on the surface of the head. There's each electrode tells us about a pretty broad swath of brain. There's not a lot of specificity to understanding mechanisms from EEG. EEG is a good tool for where and when, but not necessarily very specifically where or how. So there's not a huge amount of data in this space, but there are starting to be imaging studies of what GPFA looks like when you image either with SPECT, as in this paper, or with fMRI analysis. And the takeaway point that I want to convey without going into all the very specific details of these studies is that it is not, in fact, all over the brain at once. It's not in every cell. It's not in every region even. There are specific networks that are activated. And from this initial work, it seems very much like they are networks that aren't the primary ones. It's not, in fact, the networks that are activated are not, in fact, primary motor networks, even though the manifestation of a tonic seizure is clearly motor. There are networks like the attention network or the default mode network that undergo changes that result in GPFA and or tonic seizures. And how does that occur? We really, really don't know. We only know in the broadest strokes that something is happening somewhere in the cortex, signals to the thalamus, which relays signals back to the cortex in a much broader way that results in a seizure with these EEG findings. We don't really even know exactly where in the thalamus, and certainly we don't really know what's happening at the cellular or molecular level yet. We have some indication that certain nuclei are probably involved, like the centromedian nucleus, and this is actually the basis of work ongoing now at some centers to implants to do deep brain stimulation of the centromedian nucleus, specifically for the seizures common in LGS. So what other aspects besides EEG and these imaging studies can we think about to understand how to go about figuring out what the mechanisms are? Well, let's come back to the age distribution question. This is just extracted data from a paper looking at seizure semiology in different age groups. And this was from a EMU population. So it doesn't mean that tonic seizures aren't happening in adults. It just means that in patients admitted to an EMU, when you see tonic seizures, they tend to be in our very youngest patients. I think that this is a hugely important aspect. This is just to underline the fact that this is age dependent. That age dependence is a big factor in LGS and in tonic, atonic seizures in general, even outside the context of LGS. I think we can learn a lot by focusing on what is it in development that's happening that is leading to this seizure phenotype. So when do tonic and atonic seizures occur? Besides age, what can we learn from syndromes that these seizure types occur in? So besides LGS, we see these seizures in myoclonic atonic epilepsy, maybe with some differences. There are also some etiologically determined syndromes, single gene disorders that have a high frequency of tonic seizures. And I think we may be able to learn a lot by understanding the mechanisms of those disorders in much greater detail. Also, on the other side of it, there are syndromes where, such as Dravet, which is both clinically and etiologically determined, where there's typically no early tonic seizures or prominent tonic seizures, where the presence of early tonic seizures would actually make you question that diagnosis. And why is that? We know a lot comparatively about the mechanism of Dravet syndrome. All right, I wanted to highlight this disorder in particular because of a couple of different papers indicating that in this infantile developmental epileptic encephalopathy, tonic seizures are really very common. And I think focusing on these single gene disorders whose mechanisms we can tease out, that people can tease out in the lab and maybe develop animal models for would be hugely, would be a door into this otherwise closed space. All right, one other way of thinking about how to start getting at the mechanisms underlying tonic atonic seizures are, what do we know about which drugs work for them in particular? And many of these drugs, we know something about their mechanisms. And so how can we put that information together to understand the mechanism of the seizures? It's sort of a backwards approach. Well, it's interesting that all of the drugs listed here, which have indications for LGS, formal indications for LGS, did report in their regulatory trials significant drops, not just in total seizure reduction, but in drop attacks or tonic atonic seizures specifically. But also, these drugs have often multiple mechanisms and mechanisms disparate from each other. So I don't have answers for you about what this tells us, but I do think that it is also a sort of indirect way of thinking about the mechanisms underlying tonic and atonic seizures. And I'll just give you some examples of some may be more informative than others. So for example, this is from the long ago now study of lamotrigine leading to its indication for LGS, where there's not a, I don't know what the laser pointer is, that's okay. There's not a huge difference in the reduction of tonic atonic seizures specifically, or as it's called here, drop attacks, and all seizures or all tonic-clonic seizures, compared to rufinamide, where it seemed that this drug seemed to have a little bit more action on those seizures than on other total seizure types. And then, of course, famously clobazam, which seemed to have a marked effect on tonic and atonic seizures specifically compared to other seizure types. All right, so in thinking about how studying tonic and atonic seizures in clinical trials, even before we know mechanisms, if there is a potential drug that seems to have some early signal that this may be that it may be efficacious for this seizure type, is that this is a very studyable seizure type. It's recognizable, often countable. It's debilitating, so treatment would have a meaningful impact. And studying these seizure types versus studying seizures in LGS may be less restrictive than insisting on a syndrome diagnosis for study entry, and may facilitate trials and may tell us, I think, more about, in looking at who responds and who doesn't respond. I think we could learn a lot. And importantly, though many children, say if there were a trial of a drug in specifically for tonic atonic seizures, but not restricted to a syndrome, I think most of the patients in that trial would probably have LGS. Some may have other named syndromes, at least in their later stages. Some might have specific genetic DEEs, and many would actually have no named syndrome. They wouldn't quite be LGS. They might be near LGS, but they would have drug-resistant epilepsy and have tonic or atonic seizures, and maybe other seizure types as well. All right, so getting close to summarizing. By looking at single gene disorders and what their molecular mechanisms are, what we know about the mechanisms of existing drugs and their effect or non-effect on tonic atonic seizures, or really any other seizure type or the syndrome as a whole, I think can tell us a lot about molecular mechanisms, or that's one path into understanding molecular mechanisms. And then eventually novel pharmaceuticals based on that. I think that figuring out how molecular mechanisms connect to network mechanisms and understanding network mechanisms in much greater detail is also key, and may also lead to novel therapeutics, maybe in the form of devices. And not just mechanisms for how seizures start, but for how seizures manifest, because they may be two separate things. And there's sort of two separate possible ways of getting at what treatments might work. And then understanding, of course, again, the age dependence of these things, because I think that is really key for disease modifying interventions. And what we need, I mean, these are just a few thoughts to stimulate some further thoughts going forward, or further discussion going forward. It would be really useful to have model systems of LGS for preclinical evaluation of therapies. And I don't think we even necessarily need to insist on a convincing animal model that replicates all of the features of LGS. I think that even just having a specific profile in existing or novel preclinical screening models would be useful, in the way that the existing preclinical models were very useful for finding drugs for focal epilepsy. But I think we need more of them now, which are better at targeting the seizure types of LGS. And so even as this is happening, as we go forward with trials, not necessarily knowing all of the things that we want to know, I think we can think about and learn from trials that are designed for patients by seizure type, regardless of syndrome or etiology, as I was just describing. Trials for patients with a single etiology, or single gene etiology of their epilepsy, regardless of the syndrome or seizure types. And then trials for patients perhaps with the same network physiology, regardless of etiology, syndrome, or seizure types. And from all of that, we can start to triangulate some knowledge of what the underlying mechanisms are.
Thank you very much, Dr. Kessler. You might come back for a second. We have time for one or two questions now, and then we'll have a broader discussion at the end. Any pressing questions for Dr. Kessler right now? All right, hold your questions till the speakers all have a chance to talk then. All right, next up, infantile spasms. Just as mysterious, range of outcomes, but some kids do remarkably well. Our speaker to talk about what we can learn from infantile spasms in the LGS space is Dr. Kelly Knupp, Associate Professor of Pediatrics and Neurology at the University of Colorado. Welcome, Dr. Knupp.
Thanks, Dennis, for that very formal introduction. Yeah, thank you for Tracy and everybody organizing this. I think that many people in the room are very familiar with a lot of this work and actually have participated in a lot of the work that I'm going to present. But I think this gives us an opportunity for a lot of discussion. So I think there's some things that we can learn from infantile spasms, and I think more importantly are the things that we have yet to learn. And so I'm probably going to end with more questions than answers. Actually, I know I'm going to end with more questions than answers. So, but I think it's a good place to talk. And here are my disclosures. So as I was putting this together, there's a ton of trials, both for infantile spasms and LGS, and I felt like I needed to kind of develop a framework of how to think about this with some logical approach. So this probably isn't the best way, but it was a start of a way to compare these, to think about things before we make a diagnosis. I kind of lumped together diagnosis and treatment at the same time, because from an infantile spasms perspective, those two things often happen at the same time, and then outcomes, and raises lots of questions about, do we know who's at risk? Can we prevent disease? How do we reduce diagnostic lag? Does etiology matter? Do we even know what outcomes we're using, and are they the right ones? Do we need to reevaluate some of that? So let's walk through this and see what we think we might be able to learn from infantile spasms. And so just to compare sort of pre-diagnosis, infantile spasms and LGS, as has already been mentioned, there are numerous etiologies in both of these disorders. And so they're both very heterogeneous populations, often with overlapping etiologies in both of these. What's a little bit different about infantile spasms is it is really the entry into the diagnostic and treatment odyssey for the vast majority of patients. So for the vast majority of our patients who are coming in with an infantile spasms diagnosis, they had never met a neurologist before. Families didn't even know that there was something to be concerned about with their children until they started having these funny movements. And that is really different from the vast majority of our Lennox-Gastaut patients. These patients know neurology. They often are already being treated for seizures. Families are already concerned about development in many of these children. I think what's really tricky for us is, when does somebody evolve into Lennox-Gastaut, and how do we make that diagnosis? And I think that's really important when we think about prevention. We have fantastic data that Martina is going to spend time talking about, that is starting to give us some insight in how we can prevent infantile spasms in children with tuberous sclerosis complex. But if we don't even know when the initial diagnosis is happening for Lennox-Gastaut, it makes it really difficult to know when to start preventing it, and how to intervene right at the very beginning. And so I'm not going to spend a lot of time talking about this, because this is really Martina's topic, but just to give you a teaser that we really do have some good data for prevention of infantile spasms in this group. And this is a paper that Raleigh just recently published, which I think is important to mention, though, is it's really sobering. And I don't know if this applies to our current diagnosis of tuberous sclerosis complex or not. But in all fairness, this is a relatively older cohort that she was looking at, a cohort from the 1980s until like early 2000s. But only one child in Finland, in her cohort of 31, had a tuberous sclerosis diagnosis prior to the diagnosis of infantile spasms. So while we have this huge opportunity for prevention, we have to figure out how to diagnose these children. And that made me really think about, like, what are the possibilities for Lennox-Gastaut? I can think of lots of ways that we can ensure an earlier diagnosis for children with tuberous sclerosis. We can, make sure that we're doing really, really good ultrasounds. We can do genetic testing at the time of delivery. What do you test for Lennox-Gastaut? When you look at that newborn, what are we going to test that child to put them in a category that they may be at risk? So like I said, I have lots of questions and maybe not a lot of answers. Oh, my slides are not advancing now. We're stuck on this slide. There we go. So, but we have lots of other things to talk about. So what are the prevention opportunities for Lennox-Gastaut? And so this is admittedly data from a single institution, my institution, and it may or may not be emblematic of what's happening everywhere, but I think it's at least a place to start talking about this. And so, our question at our institution when we did this was, with better treatment for infantile spasms, have we altered how many children are evolving into Lennox-Gastaut? Our older data suggests that about a third of children with infantile spasms will eventually evolve into Lennox-Gastaut. And, we have a pretty well-defined cohort of children with infantile spasms over a period of about 10 years. And so we decided that we would take a look at this and see how many of these children are still evolving into Lennox-Gastaut. Have we moved the needle on this at all as we've improved infantile spasms treatment? And it turns out we haven't. About a third of the patients evolved into Lennox-Gastaut. We can actually identify some risk factors. So children who had developmental delay prior to the onset of infantile spasms and children who had seizures prior to the onset of infantile spasms were at increased risk for evolution into Lennox-Gastaut. So we can probably identify some of these children fairly early on. And I suspect we all know in our gut when we see these kids, who we're a little more worried about and who we're not. We're not great at predicting that, but we have a sense. And we have some data to support some of those cohorts. What was interesting at our institution, and I don't know if this is happening at other institutions or not, is that despite the fact that we have this large percentage of children evolving into Lennox-Gastaut, they're not actually getting diagnosed with Lennox-Gastaut. And I think this is really important as we think about some of our other literature, particularly if we are looking at big data. So if people are pooling, Medicaid databases and trying to look at Lennox-Gastaut, when they're looking at my institution, it probably looks like we've cured Lennox-Gastaut. And it's really just that we're not making this diagnosis anymore. And therefore we're not coding for it. And so I think we have to be a little bit cautious about, if this is happening at other institutions, if some of that bigger data is really reliable or not. It does make me wonder from an epidemiology standpoint, maybe there are far more children out there with Lennox-Gastaut than we realize when particularly if we're using big databases to estimate this. The reason we think this is happening at our institution is we are actually giving people a more defined etiologic diagnosis, and we're not moving on and talking about the syndromic diagnosis. We did see that people were circling back and giving a syndromic diagnosis when they needed it for particular medications. So for us, that was Epidiolex. So when we wanted to prescribe Epidiolex, suddenly children evolved into Lennox-Gastaut. But this does tell us that, we still, for a third of our patients with infantile spasms, there are some opportunities here for a trial to think about how we can prevent this evolution into Lennox-Gastaut. So this doesn't account for all of our children with Lennox-Gastaut, but it is a population that we may actually be able to target for prevention. Just like preventing for tuberous sclerosis complex, it's a small portion of the children with infantile spasms, but it's a place to start and a place to think about it. So I think this is a huge opportunity. So moving on to diagnosis and treatment, I've already started to step into diagnosis. For infantile spasms, for the most part, we have pretty clear diagnostic criteria. There have been several trials that look at initial treatment, which is super helpful. And, that is in part because diagnosis and treatment are so closely linked for infantile spasms. We actually have some really nice practice guidelines with recommendations, which, they're not as tight as we would like them to be, but it at least narrows things down to a handful of medications, maybe half a handful of medications. And we do think that early treatment has improved outcomes. When we look at Lennox-Gastaut, there's fairly clear EEG criteria. There aren't really clear formal criteria for diagnosis of Lennox-Gastaut. And this was a challenge for us when we were trying to define Lennox-Gastaut in our patient population, because we couldn't refer to something where there were specific criteria of what you would expect to see. There actually have been far more trials in Lennox-Gastaut than there have been with infantile spasms, but none of them have really looked at initial treatment. And we don't really have great guidelines about how we should be treating Lennox-Gastaut, and I'll go through some of this data. Insurance has attempted to address this a little bit, but quite frankly, when they address it from a financial standpoint. And so basically what they're telling us is you can't use Epidiolex until you've used these 4 other medications because they're cheaper. But we don't have any comparative effectiveness trials to tell us which one is better. So therapeutic lag, so just as we're talking about diagnosis, we know in infantile spasms that therapeutic lag is really important and impacts outcomes. So the greater the lag between first spasm and initiation of treatment, the worse the outcome. When we go back through our literature, there have been varying definitions of what early treatment is considered. So some of our very old literature from the 80s says 2 months is early treatment and delayed treatment is after 2 months. Some of the newer data out of UKIS and IKIS from Europe actually breaks this down on a weekly basis, and so is getting much more refined. And I think it's really important as we think about therapeutic lag that there are a lot of components that go into this. There's the diagnostic lag, which really entails the time when the baby starts doing something funny and the parents actually recognize that something funny is happening. And then they get to an appropriate provider who makes that diagnosis and figures out that they have infantile spasms. So there are a whole host of things that contribute to that. In most cases, as soon as a diagnosis is made, that treatment happens pretty quickly, usually within 48 hours or so. I think this looks different if we were to look at this from a Lennox-Gastaut standpoint. There are a whole bunch of different factors that would go into all of the things that would contribute to therapeutic lag. My title is cut off here, but this is more about therapeutic lag. and just to emphasize that this is important, we actually have both older and newer literature that children who have early treatment, whether it's defined as 1 month or within 1 week, that we actually see improved long-term outcomes with normal development. We also see improvement in response rate with earlier treatment. So we know that this is important and that therapeutic lag is a very important thing for us to look at. And quite honestly, from an infantile spasm standpoint, it is one of the few modifiable risk factors when we're treating infantile spasms. We can't necessarily change somebody's etiology, but we can change that time from first spasm to treatment. One of the other things that we see in diagnosis of infantile spasms is that for the most part, we have some clear criteria for an EEG diagnosis. There's still a lot of debate about this because that's what we like to do as epileptologists. But we do have some formal ways of doing this. The BASE score is one of these, and it's the one that I have most commonly used. But it really provides a standard approach to a diagnosis of hypsarrhythmia. And it allows for my institution's read of hypsarrhythmia to match up with another institution's read of hypsarrhythmia. We still don't really know what to do if we don't have hypsarrhythmia. So there's still, area for improvement there. I think we probably need something like this for Lennox-Gastaut. I think we all know what slow spike and wave looks like. We all know what paroxysmal fast activity looks like. But what does it look like as we see evolution into that? How much slow spike and wave do you need to have a diagnosis? We hear from our adult colleagues that they don't really see slow spike and wave anymore. And we know that too. We are more likely to see it in children under the age of 10 than children over the age of 10. And so, what are the EEG criteria that we need to make a diagnosis of Lennox-Gastaut? And honestly, does everybody meet that criteria? We know in infantile spasms that you can have the seizure type and not have hypsarrhythmia, and we still say that you have infantile spasms. And we may need to think a little bit more broadly about Lennox-Gastaut and may need to think about how much EEG abnormality do you need to have. There is a retrospective study that started to look at these early EEG findings in Lennox-Gastaut, as Tracy mentioned earlier. I think we all see patients who have infantile spasms, and we see that they're going to evolve into Lennox-Gastaut, but we haven't really quantified what that really looks like. And I'm hoping my pointer works here. Is there a pointer here? Oh, goodness. It seems like there should be a pointer. I just can't figure out how to make it work. Ah, there it is. So what I really want you to look at is sort of the middle of this of this table here. And what we, and I have to say, like, I think that there's some really useful information from this paper, and I think it's a really good start. We again see that about a third of patients developed Lennox-Gastaut. So these were patients who had infantile spasms and then evolved into Lennox-Gastaut. It took time for these patients to evolve into Lennox-Gastaut, so we really have to watch them for a while. But we will see for some of these patients, it took them several years before they got to a clear diagnosis of Lennox-Gastaut. What I struggle with this though is there's a huge variety of abnormalities on these EEGs. So some of these patients had focal epileptiform abnormalities, some had multifocal epileptiform discharges, some had slow spike and wave as they were evolving into Lennox-Gastaut, and some had burst suppression. So basically this sort of tells me that if your EEG is abnormal, you may be evolving into Lennox-Gastaut. And I think we all would agree with that, but it would be nice if we could quantify this a little bit more with something that would tell us who is and who isn't going to evolve into Lennox-Gastaut. They tried to group these into 4 groups based on etiology, and I'm not going to talk too much about that because I'm still trying to wrap my head around it, quite honestly. But I think there is some work there. I think we all know that there's a huge list of treatments for Lennox-Gastaut, but we don't have any comparative effectiveness trials between these treatment options. And I don't know when I'm supposed to use one over another. And so I often in my practice find that I am choosing this based on parental perception of the medication, which right now moves cannabidiol up very high on the list, maybe looking at side effect profiles, things like that. And so it can be very challenging to know which one of these medications we should be using and is it important to use them in a particular order. When it comes to looking at outcomes, we have a very well-established outcome for infantile spasms, which includes both resolution of seizures and EEG. And it really is sort of an all or none outcome. For Lennox-Gastaut, we do have seizure outcomes that are well established, and what is being used much more frequently are seizures associated with a fall. But we're not looking for resolution. We're really just looking for some reduction in seizures. And so I'm not sure how much in the end it's really altering the underlying process of Lennox-Gastaut. It's just really symptomatic treatment that we're looking at. We do have long-term developmental outcomes for infantile spasms. I'm not sure in Lennox-Gastaut that we're really looking at any of these long-term outcomes, and I'm not sure that we're really looking at outcomes that are important to families. I do think that seizure reduction is important to families, but I know from talking to lots of families and from talking to lots of family groups that seizures aren't the only important outcome. There are, decreasing the risk of SUDEP, managing behavior, getting a good night's sleep. All of these things are incredibly important, and in a particular day or month may actually be far more important than the seizure control that somebody is seeing. The long-term outcomes haven't really been well established for Lennox-Gastaut. All we know is that, we see intellectual impairment and ongoing seizures throughout the lifespan, and that, it would be better to fine-tune this a little bit. So this was an interesting paper that I found. I was, really trying to figure out, has anybody tried to tackle comparative effectiveness and what we use in what order. And I thought this was a nice summary slide. So this group actually went through and looked at care guidelines that had been created for a variety of different disorders. And this particular table is for Lennox-Gastaut. And, so they went to institutions and looked for their guidelines if they had treatment guidelines, and then also looked at national guidelines. And they identified 35 guidelines for treatment of Lennox-Gastaut. And then they went through to see how, of these medications, which ones were recommended and not recommended. So green was recommended in those guidelines, and red was not recommended in the guidelines. And then if it wasn't mentioned at all, it wasn't noted. And you can see there's a whole lot of green here. So we have a whole lot of treatment options to use, but it doesn't tell us in what order. I suspect that we could probably think about this from a crowdsourcing standpoint, that if 31 guidelines are recommending lamotrigine, it's probably something that should be on the top of our list. It may be that it has fewer side effects or, it also could be related to the age of the medication. So again, comparative effectiveness trials would be particularly helpful, I think. I had this slide from a talk a while ago, and I think, going through the literature, it probably still provides one of the best frameworks. This is from Adam Ostendorf, who tried to come up with some logical approach of how to treat infantile spasms. But I think there are issues here, and one of the biggest issues is you really kind of start here in the middle instead of with first seizure. And so, we again have this list of medications, and I have no idea which one I should be using over another. This probably looks like the list of medications that I use. This hasn't been updated, so it doesn't have cannabidiol on there. Fenfluramine will hopefully be coming in here as well. I do like that it recommends surgery, because that is one of the treatments for those patients who are surgery candidates that has some of the best outcomes. But we don't have anything that's really scientific that tells us what to use one over the other. And so this is a huge opportunity for us. So I know that I've raised even more questions than probably are even on this slide. So I'm going to end here. I highlighted some of these that I thought would be sort of more reasonable targets to talk about sooner rather than later. I think how to prevent disease is probably at the crux of this. And how do we reduce that diagnostic lag? I think those two things kind of go hand in hand. If we're reducing diagnostic lag, then that leads to reducing treatment lag. What are the best treatment options? Comparative effectiveness trials would be really, really helpful. Are patients getting the right treatments? This is something that we found when we did our observational database for infantile spasms, is there are a number of children who were not getting the right treatment, and we could see it in their outcomes. And so, looking at an observational database for Lennox-Gastaut may actually bring some of that to light. How do we measure outcomes, particularly looking at those long-term outcomes? I think we know how to measure seizures that are associated with a drop, but I'm not sure that those are the most important outcomes, and they're not long-term outcomes. And what do we do if treatment fails? This kind of gets back to what order should I be using my medication in, and are there some combinations that are better than others? And so with that, I will close and let Dennis decide if he wants to talk about these now or later or at all.
Any pressing questions for Dr. Knupp? So there's an urgency surrounding infantile spasms diagnosis and treatment that is frankly not there with LGS. And I wonder if it should be. We can think about that for our discussion period. Thank you very much. All right, next up, tuberous sclerosis. Anti-epileptogenesis, perhaps a true AED as opposed to an ASM, anti-seizure medicine, and mechanistic-based treatments. Very exciting advances. Our speaker is Dr. Martina Bevin, professor of neurology at University of Alabama, Birmingham, to give us an update on the very exciting developments in TSC and what LGS can learn from these advances. Thank you, Dr. Bevin.
Good morning, everyone. Thank you, Dr. DeLugos and Tracy, for inviting me to come and talk with you. So I wanted to just talk about, the question was, what can LGS learn from what we've been doing in tuberous sclerosis, and really to advance the clinical trials in LGS. So what I wanted to talk about, we're kind of in a unique situation, those that study TSC, but there's so many parallel kind of paths that I think LGS is taking, which is really wonderful and I think exciting. And we can kind of learn from what we're doing in TSC. I think the premise that when we think about epilepsy and TSC is this whole idea of anti-epileptogenesis. And we're in a position where we're dealing with one genetic disorder. And infantile spasms was such a front and center issue in patients with tuberous sclerosis in the first year of life. And all of us have seen these children in clinic. And when I started my training years ago, that we often didn't see a baby until they had been having spasms for 1 to 2 months, but this has dramatically changed for a variety of reasons. And one of them is the prenatal diagnosis, which I'll talk about. But you can see from this illustration that you start with a mutation, and you have this pre-epileptogenesis period of time. We call a latent period, before even the first epileptiform activity presents itself. And probably in studying this population for almost a decade now, we may see it as early as 4 to 6 weeks, but in the majority of time, the epileptiform activity appears around 2 to 3 months of age. And in the preliminary work, which identified the biomarker, we realized there's a window of time of about 3.5 months when the first epileptiform activity appears until you have the evolution and the presentation of the first clinical seizure. Now, what was kind of confirmatory and a little bit surprising, but none of the babies in the original biomarker study that we did had a hypsarrhythmia at the time of their clinical presentation of infantile spasms. And I've come to the realization that if you do see a hypsarrhythmia in a TS patient, it's kind of the horse is already out of the barn. So that's really driven this urgency to identify these babies early, to be part of the discussion with the family, really in the nursery if we can, and have a conversation about what the next 12 months is going to look like. Education of the family, teaching them how to recognize seizures. So it's really been a game changer of our clinical approach to these babies. And we really aim for the neurologist to be with the family at the bedside and be directing the care well before, weeks before they ever have the first seizure. So this whole idea of epileptogenesis has driven this change in clinical practice and our efforts to really be on the preventative side, because that's the goal. And the goal is the child to never have a seizure, but we're certainly not there yet. But I think taking this approach has really changed our mindset of, we didn't realize what we didn't know. And there's so many things that we're doing now that are shaping the progression of the epilepsy. How do we impact that? And then equally as important is how do we impact developmental outcomes? So it's not only the seizure management, but it's what we're doing in terms of early intervention services and some of the early intervention kind of more investigational approaches on intervention therapies that are changing the outcome in terms of risk for autism, and also our understanding of autism and what is really in that diagnosis. So really this critical window right here of this latent period has kind of set the stage of what we have been attempting to do, because we know that it affects what's the long-term trajectory of the epilepsy, the degree of cognitive impairment, and the developmental delay. So this is kind of the foundation of how we work in tuberous sclerosis. And again, we're in a very unique position, but I think it's so important for clinicians to take advantage of the tools we have to make the diagnosis early. One of them is really have the mothers have the prenatal care and the high resolution ultrasound, and specifically contacting the perinatologist, the OB. I mean, I'm calling the high risk OB and the ultrasonographers and saying, hey, would you please look at both the heart and the brain and let me know if you're seeing anything. Also, I think the partnership with Pediatric Cardiology is absolutely critical. I would say most of the referrals that I get are from the pediatric cardiologist that I've worked with for over 10 years, and he lets me know when they've identified a baby. So we're meeting with these families well before the delivery. So the family is prepared and they've had time to process this. And you can see that about 80% of the fetuses or infants that are diagnosed in the nursery have evidence of cardiac rhabdomyomas. And they also have about almost half of them have arrhythmias in the nursery. So that's really the number one way we're finding these babies early. Yeah, and also I think the the number of fetal MRIs has gone significantly, has increased, which is great because we're also looking for the subependymal nodules or the cortical tubers, and there can be identified in the MRI. I think this early diagnosis, like I mentioned, I think it's imperative for primary care physicians not to wait for the first seizure. They need to call the neurologist and they need to contact a TS clinic, because there's well over 50 in this country now, and have talk to the director of the TS clinic and ask for the child to be seen. Because in many ways you can help confirm the diagnosis, get the diagnostic workup completed early. And that's so much, you've got a path of what you're dealing with and what the plan is for really initially the next year. And then we've developed with the TS Alliance, there's some really good websites and internet resources for families to go look at what seizures look like. We spend some time. We are very open in terms of families sending videos, so they never have to worry about bothering us. We want to see them, and it's a quick turnaround. We usually answer them in an hour or two during the business week of what we think is going on and then what the next steps are. And I think that EEG monitoring has really been a cornerstone of us beginning to understand this whole idea of epileptogenesis and what is going on. So I just thought about what was the foundation that facilitated the advances in TSC that we've been able to impact really over the last decade, because most of our research that's been funded has been really from birth to 3 years of age, because we know that's the highest risk. You know, over 80% of these babies are going to present in that first 3 years, and 2/3 are going to present in the first year. I think the natural history study database that the TS Alliance started about 10 years ago has been really helpful, because it gives you the clinical natural history of what happens in this population. And there's over 2,000 patients in that database now. We also have been, I'm very grateful for this, have been very meticulous in being uniform in the way we've collected data over the 4 different NIH funded studies that we've done. And we're merging them into one database, and it's going to be the clinical history, the EEG, the neuroimaging, the genomics, and then we've partnered with the Alliance to have the tissue repository in Van Andel Institute in Grand Rapids. So there's genetics, there's tissue, there's the clinical phenotype, and then we're building the imaging resource as well as the EEG resource. So I think over the years going forward, we're going to be able to really data mine and understand this even more. I think one of the things that I've realized in looking at these babies, particularly those in the prevent, you can really see the evolution of the EEG and they're done every 6 weeks over time. And I think that's been a huge advantage to be able to intervene well before there's evidence of a hips arrhythmia. And I would say it's pretty standard that if I see a video of a clinical spasm and we've had preceding epileptiform activity on the EEG, you know, you don't need to wait. You've got to initiate treatment. And I think the response in those scenarios, because you're intervening early, has really been within 24, 48 hours in most of the cases. I think looking at epilepsy susceptibility, we know that the TSC2 mutation is more highly probable that they're going to develop seizures than TSC1. So I think the genetics is very helpful to have from the beginning. And I think if we go forward with more disease modifying therapy, and ultimately the holy grail is gene therapy, this is critical that we know each patient's mutation. There's also probably modifier genes, which there's active interest in looking at also. And I think one of the things that I've learned is the seizure semiology is different than what I thought of 10 years ago. And I think only because we looked and found these babies from the nursery and had the families video them, we realized what we didn't know. And I think in the very, very young, many times the seizures are a negative phenomenon. It's what the baby doesn't do or stops doing. And that would be easily missed if you didn't have the parents' video examples and then many times brought these babies in for EEG monitoring. Because it can be a subtle eye deviation, a change in facial expression, a loss of movement than what we classically think is a seizure. So many of these babies have that before they even have a clinical spasm. And we really came down to thinking of it as in thirds. Most have focal seizures, some have a combination of focal seizures and spasms, and then just some have clinical spasms. And one of the things I always remind myself is when we did originally the biomarker study and looking at identifying the biomarker, none of these babies, when they initially presented with seizures, had a hypsarrhythmia. So it tells you there's so much going on before that first clinical event. So what are we doing now is I think there's more refinement in the biomarkers and looking at spectral array. We're looking, it's a network issue. How do we better understand that? Looking and correlating neuroimaging with DTI and then looking at tuber load and connectivity. And then one of the important things is the developmental assessments, because we realized those, the group that really has refractory seizures, those are the ones that are at risk for their developmental issues and the risk for autism. And what's interesting is when you look at these babies at a year and you do like a Mullins or a Vineland, they're going to score, most of them are going to score in the normal range. It's going to be low normal for those that are in trouble. At 2 years, they still may be in the normal range. So you can't just take one data point. You have to look at progression over time. And you can see that those that have developed refractory epilepsy, really between a year and 2 years, they break out and you can see their downward trajectory developmentally. So it's that change over time. And even though they may be low normal, that's a red flag that those children are at risk. And so not only is this changed I automatically say every child with starts having seizures in the first year with TS goes and gets screened for early intervention. I insist that they stay in early intervention, even though they may come out normal. The biggest issue has been their expressive language communication. So heads up to the speech therapists that we need their services and them to partner with us as we go forward. And I think one of the nice things is some of the work that's come out of UCLA with Shafali Jesti is in the JETS program and some of the newer kind of interventional developmental therapies that are being developed. We're sending these children when they're out of the study, or if they're not in the study, to participate in those programs, because a lot of this has been remote learning, the implementation of telemedicine with the family, the weekly check-ins. And I think there's so many benefits to that, because not only are you helping the child, but the family is being proactive and engaged in learning therapies that they can do at home. And I can tell you, just in comparison to children that I saw 15 years ago, it's interesting is that we used to be able to make the diagnosis of autism much more clearly. And I think now it's not as clear. And I think the difference is because of what we're doing. We're intervening early. We're trying to be on the preventative side of the epilepsy, the early intervention services, some of the more investigational therapies that are being tried and applied. So it's not, the children with TS may have some autistic mannerisms, but they don't fit the classic diagnosis of autism. So it's really kind of turned the neuropsychologists' assessments on their head, and so I very rarely now have them at 2 say, yes, they're autistic. Usually we have to wait until they're 3 to 5 to really have a firm diagnosis. So I think all of these things that we're doing are extremely important, and it's really a balance between knowing what we're up against in terms of making the diagnosis and watching the EEG and intervening early, and then also the development that we're trying to tackle and change the developmental outcome. There's also great interest in searching for blood biomarkers. So we're not just totally relying on EEG. There is some either through genomics or there's some other interesting ideas about what may be identified in the blood related to what's going on in the brain and the epileptogenesis from the tuber areas. So, you know, it's an exciting time. I think it's a very humbling, I'm very humbled by all of this because we realize our work isn't over and there's so much more we have to do. But I think you all it's nice to hear what you all are doing because I think it parallels very much what we've been doing. And it's, you have a taller order because there's so many etiologies. But I think having this type of foundation totally directs what you have to tackle next. And, you know, I appreciate you asking me to come and talk a little bit. Thanks.
Wait, this is Tracy from the LGS Foundation. I'm wondering if we could get all the speakers to come up too while Dennis is giving his remarks, because I have questions for all of you guys.
Come on up. Yeah, so I am stuck on the point of early diagnosis. You know, we don't talk about early diagnosis of LGS. And we do, I mean, tuberous sclerosis, there are opportunities biologically, infantile spasms, we talk about that. Early, it's almost like we avoid the diagnosis. Parents don't want, oh no, not LGS. I think we need a culture change, which is not going to be so easy to do. But anyway, that's my thought from hearing the three talks. Early diagnosis.
Yeah, I think you're right. I think that with the genomic revolution that we've had a lot of doctors sort of shy away from, instead of, you know, giving the diagnosis of LGS secondary to your gene mutation or secondary to your hypoxic ischemia. We're seeing a lot of doctors that will just give the gene name, right? Like you have SCN8A epilepsy, and I don't need to give you the LGS because SCN8A is bad enough, right? But you also don't then get the services that come along with LGS or the sense of community. We don't have a lot in LGS, but we have a community. But so we have people at home and we only have about 5 minutes for questions. So I'm just gonna, if you have any questions, please raise your hand, but please use the microphone if I ask. So I wanna start with you, Dr. Kessler. Has anybody sat down and tried to do the triangulation, right? So you've got a series of drugs that act on specific mechanisms. You have a series of gene mutations where atonic and tonic seizures are present, and a series of gene mutations where they are not. And then you have this age-specific onset, and then there's some functional neuroimaging that's coming out, at least in LGS. I'm not sure how much there is in like the gene-specific epilepsies, but has anybody sat down and tried to triangulate the mechanisms for this at all?
Not that I know of. I don't know if anybody else has any comment about that, but yes, the point I was trying to make is that I don't know if that will crack things open, but it seems like instead of repeated investigations that look at it from one angle, the next step is to do that sort of multimodal look.
I guess my other question is our atonic seizures, and I'm not sure who this is for, but our atonic seizures and the emergence of them, since they're age dependent and they're bad, right? I don't think anyone agrees they're not bad. Is that a point for early intervention? Like Dr. Bevin, you were talking about that. And is when those emerge, is that the time where we should be being aggressive? And then I'll just add to that question, and you guys can all just comment on this, but as Dr. Knupp, you were talking like, which one should you use first? Well, maybe it's a combo. Maybe it's a cocktail. We actually posed this question in the LGS group recently and said, what do you wish you had tried sooner that was effective? And it was keto. We had 105 responses and it was just keto was an overwhelming winner. And so I'm just wondering what you think about this concept of early intervention. Any of you guys can answer, but also is there any work looking at a cocktail? Because I don't think we have a clear transformative therapy. And then also, you know, has anyone thought about the keto, right? So I don't know who wants to go first.
I think those are all great questions. And I was standing, you know, the first question was atonic seizures. Is that when we should intervene? And I don't know that we have a good natural history study to know when those come out. So honestly, that would be a great could potentially be a great marker, but I think we have to do the natural history study to figure out when do we see those atonic seizures and how does that correlate with the evolution of the syndrome. I agree with you. I think keto diet is a great intervention. I don't know that anybody's really looking at any comparative effectiveness work, whether it's keto diet, combinations of meds. This is a place, all of these questions, we would at least start to get some answers with if we had a good natural history observational trial or study to look at that. I think we could start to answer some of those questions and at least give us some clues of where we should go next.
Yeah, if I could add, I think the options for early intervention would be the new onset of atonic or tonic seizures, or appearance of slow spike and wave or GPFA on an EEG when it wasn't there before. Those are the because most of these kids already are part of the epilepsy world. Many of them, and I'll just pick on levetiracetam, so it's so widely used, maybe on levetiracetam, but probably not the best drug if you now have evolved into LGS. And your point about combination therapies, early keto, something that bugs me is that incremental progress impedes transformative progress. We have 7 medicines with labels and FDA approvals. LGS, I'm sorry your child has LGS. Here's how we'll start clobazam, we'll start cannabidiol, and you go through the list. And then at some point, you might get to valproate lamotrigine or keto diet. So we've got so many treatments that actually impedes, I think, an early, more aggressive, if you will, intervention.
Great. Well, I think we're at time. Any questions from the room? Yep, back here. Couple, great. If you could just introduce yourself.
Hi, I'm Raji Mahalingam. I'm a pediatric epileptologist. So this question is for Dr. Bevin. So thank you for the excellent presentation. So in terms of early treatment or even early recognition, even way before LGS and tuberous sclerosis patients, I know there are studies that talk about Sabro, even before the starting of spasms. There are some studies. Is someone looking into starting mTOR inhibitors, say, at time of birth, when you know that the child has tuberous sclerosis, to kind of even prevent the downstream effects of tuberous sclerosis, not just epilepsy, but the tumors and other issues?
Actually, perfect timing, because the FDA just approved a trial that the consortium is doing. It's called STOP2, or another name, you may see it if you look on clinicaltrials.gov, is STEPS. And what it is the initiation of an mTOR inhibitor under 4 months of age. Very similar design as the PREVENT. You don't have to have epileptiform activity. It's just started. In the children, it's placebo double blind. It's a 1-to-1 randomization, and the children are treated for a year. If they develop seizures, vigabatrin is started. So this is trying to answer the question of really multi-organ system impact in terms of using an mTOR inhibitor, because and the history behind that, why we picked vigabatrin first to do preventative therapies, because it was FDA approved in this indication in infants, and we knew that it would be almost impossible to get the approval, the IND, to do it on an mTOR inhibitor in an infant when we didn't have the labeling. But the FDA recognized just the mechanism, action, and disease modifying impact of mTOR inhibitors. So if you're interested, there'll be multiple sites across the country. There are one site, and then we're supposed to be starting enrolling in January. But look it up, and you can look at the details.
Great. Any other questions from the audience? I think I saw another hand. I'll go here. She had her hand up before.
Hi, I'm Amanda Powell from Mid-Atlantic Epilepsy. We have a couple of clinical trials going through our center for LGS and TS, not so specifically for TS, but sort of included in refractory epilepsies. And I was just wondering if you guys had any opinions on serotonergic and cholesterol pathways in terms of how they might be a novel target. Do you have any broader feelings about those, like locastrin for serotonin or for soticlestat, if you have any thoughts?
I will say we will find out, because as you know, I'm a little skeptical about mechanisms of action, because even if we think we understand, we don't really understand. But some of these new novel investigational products do have unique looking mechanisms of action, and the trials are started or will start soon, and we'll see. In particular, side effects. Because, you know, it's not just seizure reduction, it's with acceptable side effects. So hopefully we'll find out, but I think we're going to have to do it just through the empirical clinical trial means. We don't understand enough about mechanisms to get too far ahead with how the mechanisms could really make a difference, but we'll find out.
Enrique Carazan with Neurologist. For the panel, thinking about what Martina spoke about, are we ever going to get to the place where we can do an early diagnosis of LGS really, really early? I mean, because is it when we see atonic and tonic seizures, are we too late? I mean, because if you think about TS, you're looking at prenatal, you're looking at, you know, ultrasound with rhabdomyomas and cortical tumors. Can we get there? For example, take that patient with the polymicrogyra that Dr. Kessler saw the MRI. If we had that MRI early on, shouldn't you be able to predict that perhaps the LGS was underlying? Just thinking about how do you get there, that early diagnosis?
Yeah, I mean, I think we just first need to agree on, as Kelly said, when is it LGS? Like, exactly when does that happen? We really don't have that well defined. And then I think that the big obstacle with something like an imaging abnormality is that there is a huge amount of heterogeneity. I have a kid with a very similar MRI that didn't start having seizures until he was 12 years old, and those were focal seizures. And so you know, but I do think natural history studies would be enormously helpful, paired with whatever sort of biomarker, whatever biomarkers we could get.
I've always sort of wondered, this is Tracy from LGS Foundation, for those at home, always sort of wondered if there's like a risk factor score, right, for the early life epilepsies. You know, Kelly, you pointed out one that is if they had seizures before IS and if they had developmental delay before the onset of IS, that they were more likely to develop LGS. So looking into that. So we are at time. Thank you guys all for coming. Thank you all at home. This was very informative and helpful for those of us at the LGS Foundation. Lots of things we need to do, lots of ideas. But hopefully you guys will, you know, continue the conversation as part of our seminars as we're moving forward. And I have so many questions for you guys. I think that our next Meeting of the Minds conference in 2 years would be on these clinical questions specifically, and we can start building and moving things forward now, but really focus on maybe thinking about how do we look at guidelines. There's a comparative effectiveness trial right now on surgery versus the next seizure medicine. I don't know how much information they're collecting on the next seizure medicine, but it'd be great if they were collecting at least some info on that, as opposed to just surgery versus the next thing. So we have a lot of work to do, but thank you to the amazing speakers. And I know it's early, but we can give them a round of applause. And thank you guys. Appreciate it. Have a good day.